some lubrication, also some alkaline. Also, prostate and seminal vesicles tend to have some more alkaline secretions than the urine. But the bulbourethral, those are called pre-ejaculate secretions. They will lubricate the penile urethra, preparing it for the sperm that will arrive via the vas deferens, and then the secretions from the prostate and the seminal vesicles. The vas deferens, this is all posterior of the bladder. You can see the ureters entering, they enter posterior on the bladder. The gonads get pulled between the ureters and then down into the scrotum. So on their return from the scrotum, they're going between the ureters and then coming down towards the prostate. The seminal vesicles, prostate secrete into the prostatic urethra. They'll be joined by fluids from the tail of the epididymis and the sperm from the tail of the epididymis, and they will form the ejaculate. Okay, so just another view we saw already. So from the prostate, you have the penile urethra. Penile urethra is in some more tissue that's kind of spongy. It has openings in it that can fill with blood and create part of the rigidity for the erection. That tissue is called the spongy urethra. This tissue is called the corpus spongiosum. So the urethra in that's surrounded by that part is sometimes referred to as the spongy urethra. And up above that is the corpora. There's two of them. Each one is a corpus, which is a body. Corpora means bodies. Cavernosa. The center of the corpora cavernosa will have these penile arteries, also referred to as helice arteries. They will bring the blood to this tissue, and then the veins will take the blood away when the penis is in the relaxed position. When it is under parasympathetic arousal stimulation, then this will become very engorged with blood. The penis will become more erect, and then the outflow will not be accessible, so the blood is trapped in the penile tissue. The penis has the corpora cavernosa have these extensions that are referred to as the legs of the penis, and then the corpus spongiosum has kind of a round structure that's referred to as the bulb of the penis. And that's proximal. And then distally, the spongiosum also enlarges and forms what's called a glans. And there's a skin over that, and then there's another skin over that, and that is called the prepuce or foreskin. So if you've had a circumcision, they have taken that prepuce and cut it away, usually as a child, because the child, they'll yell and kick and scream, it hurts because surgery. But if you have it done as an adult, then you're still going to anesthetize, but after that, it's a really, really painful type of situation. So very few males elect for circumcision when they're an adult. It used to be, I would guess, probably between the 1900s and maybe the 1980s, automatic circumcision. Didn't ask the parents, just did it. And now the doctors will actually ask the parents, do you want the male child circumcised or do you not? This circumcision came from the Jewish faith. You know the history. They were out in the desert. They didn't have access to water. Hygiene was important. And so having this foreskin removed, where you don't have access to soap and water to clean under there, you reduce the infections in that area. So that was something that was introduced via the Hebrew religion. If you teach proper hygiene, you just pull the foreskin back, wash underneath it, and then pull the foreskin down. It's fine. So with proper hygiene, no problem to keep it. It looks different if you have a foreskin versus if you are circumcised. So some people, because majority have circumcision, they like to have their kids go that route too. Female, you had, instead of the mesonephric duct persisting, now the paramesonephric duct persists. And it's going to fuse in the midline and form the uterus, and it's going to remain out in the area of the gonad. It's going to form the fallopian or uterine tube, and then the gonads, they will get pulled by the gubernaculum away from the posterior abdominal wall, but they don't get pulled down through the inguinal canal. They just are still in the pelvic cavity, kind of supported by the peritoneum that got pulled away from the posterior abdominal wall. So they're out there, they have a true ligament supporting them, holding them to the posterior abdominal wall, and then another ligament, an ovarian ligament, that will connect them to the uterus. The fallopian tube, and then the end of it is going to dilate and form a lot of little fingers called fimbria, which mean fingers. Those will have a lining that has a very sticky mucus and then a lot of ciliated cells in that area during the time of ovulation. Those fimbria will actually go over the area of the ovary that's going to have the ovulation occurring. So the oocyte will be pushed out, and then the fimbria and the cilia the mucus will catch it, and the cilia will beat it into the fallopian tube. The lining of the uterus, we have endometrium, which has two layers, a functional layer, which comes out as the sloughing off of the tissue during the menstrual cycle, and then a basal layer that will remake the functional layer. The endometrium, underneath it, you have muscle, smooth muscle, so myometrium. And then external to that, you have perimetrium, which means around. And then on the outside of that, you've got peritoneum, which is usually just referred to as a serosal covering. At this end, you got specialized cells forming the cervix, and they project out into the vagina, forming kind of an arch called the fornix of the vagina. The cervix is actually producing the secretions that keep the vagina nicely lubricated. There are little bits of glycogen storage in the vagina. That sugar is then used by the bacteria in the vagina. They aromatize it, they ferment it, and keep the vagina in an acid pH. This protects the female from other bacteria getting into that area. So you have friendly bacteria that create the acid environment. Remember these delicate little sperm? They're arriving in a whole mass of alkaline pH secretions from seminal vesicle and prostate. That's to help to neutralize the acid of the vagina. Other important things arriving with them, we'll talk about that later. Right in front of the vagina actually connected together by this connective tissue is the urethra and then the bladder. Normal position of the uterus is in this anteversion, which is in front, right over the bladder. When the baby develops, it gets bigger and bigger, goes forward, sits on the bladder. Mom's got to go to the bathroom quite frequently. If the uterus is too vertical, hard to keep a baby developing to full term. If it's flexed too much forward, hard to get the sperm through that sharp angle and out for fertilization. If it's folding backwards, it's called retroversion. Sometimes when the baby is developing, the uterus becomes vertical again, and that puts a lot of pressure on the cervical plug. It might be hard to keep that baby developing. So here's your suspensory ligament. The blood vessels use that to get to the ovary. Your ovarian ligament links the gonad to the uterus. The uterus develops from the tube that was called paramesonephric tube. It's now going to form the uterine tube or fallopian tube. The fusion in the center forms the uterus, the cervix, and the small part of the upper vagina. We've got ureter going through the peritoneum to the bladder. We've also got a uterosacral ligament that helps to stabilize the uterus down below. This term os means opening like mouth. It's not os as in ossification. So we've got two osses. We've got an external os in the cervix and an internal os in the cervix. Vagina has these folds called rugae. Cervical glands produce the mucus that keeps the vagina healthy and well lubricated. The development of the female system, the mesonephric duct should degenerate. The paramesonephric duct persists. The paramesonephric duct will fuse in the center and form the uterus, and then this will dilate and form the fimbria. This will be your uterine tube and the end of the uterine tube. The gonads, the ovary, will stay in association with the paramesonephric duct, and the fimbria will move to wherever that ovary is going to ovulate at the time. The ovarian ligament is part of your gubernaculum. This is the gubernaculum of the ovary. It attaches the ovary to the will fuse with the backside of the uterus. So that's one reason why the ovaries aren't going anywhere once that happens. The gubernaculum will then continue on down, and it will go through the inguinal canal, and then it will go into the tissue in that area. I think your textbook corrected this, but at one time it said it fused with the labia minora. How that would be really sensitive. Labia minora is the very tender tissue that's around the labia majora, which is the fatty, hairy stuff. So that was wrong. It's going through the inguinal canal and then into the tissue in the area of the mons pubis. The ovary, if you cut through it, it's going to be once you hit puberty, it's going to be in various stages of recruiting cells, developing the cells, getting ready for ovulation, and then once the oocyte is ovulated, then the cells that remain in that follicle will mix together and start to produce progesterone that will then get the uterus ready for implantation. ovulation should fertilization occur. So these yellow bodies, you might see several in ovary, ones that are getting smaller because they're from a previous cycle, maybe 2 cycles ago, a big one from the last cycle, and then you've got developing follicles getting ready for the next month's ovulation. So we've got, when we're born, well, before we're born, we have huge numbers of primordial follicles. When we're born, us females, we've lost the majority of those. We have about, somebody said around 450, 550 primordial follicles left. And at puberty, they start to be recruited. They start to develop cell layers around, and the cell in the center then becomes your oocyte. So these are the these are the primordial follicles. They will have a cell in the center and simple squamous cells around them. And then when the cells become cuboidal, then you have a primary follicle. And that will then get more and more cell layers. When you get a fluid-filled sac there, then you have, well, they're changing the terms now, but a secondary follicle or an antral follicle, probably stick with that, that's the best. That gets bigger, that antrum fills with more and more fluids. The cell that, the oocyte that's in this follicle here, it's the cells that surround it will have developed their own receptors for luteinizing hormone. So their production of estrogen will go up very quickly. These other follicles, they don't have receptors for luteinizing hormone. So they have to rely on the cells outside the follicle to produce the androgens that then the cells can convert to estrogen. So they're going to be a little slower in developing. That's why in humans, usually there are 1 cell ovulated per cycle. Occasionally, more than 1 will be ovulated. You get fraternal twins. Sometimes fraternal twins run in families that everybody in that family is likely to have fraternal twins. That's when more than 1 egg is ovulated per cycle. Mature follicle that's getting ready to ovulate, or Graafian is another term for that mature follicle. To get the egg out of the ovary, you've got to rupture the tunica albuginea. So when you see an older woman's ovary, it's got a lot of black spots on it, a lot of scar tissue where eggs have ruptured through the tunica albuginea and left the scar tissue behind. So various stages of development. We've got the beginning of fluid collection, so secondary follicle. Here there's a big antrum being formed. At this side, the cells that are anchoring the oocyte to the inside of the follicle are starting to break down. Those cells are called the cumulus, and when they break down, that's in preparation for ovulation. The smooth muscle that's around the follicle is going to constrict, put pressure on the fluid that then will push against the tunica albuginea. You're going to decrease blood flow to the outer surface of the ovary, which will weaken the wall. So you got a weak wall and pressure behind it, rupture out. And that's what's happening here. The oocyte is rupturing out. It doesn't leave as a naked egg. It's haploid. It will be attacked by the immune system right away. So it's covered by the follicular cells. They're called granulosa cells. And they will go, these cells around, they're called the corona radiata, the radiating crown of this oocyte. They will go with it. They will be diploid. They will protect the internal oocyte from the female's immune system. But the sperm that arrive have to get through all the cells to penetrate to get into the oocyte. So one sperm's not going to do the job. You gotta have several hundred, sometimes 1,000 little guys attacking. One wins, gets through, gets decapitated, sets off a cortical reaction. No other sperm can get through. The cells that remain, the granulosa cells and the cells outside, they mix together, start producing progesterone. They produce this yellow color, and that's called corpus luteum, which means yellow body. When no fertilization occurs, it starts to degenerate. So this is an older corpus luteum that hasn't, the posting said it was a tunica, was a corpora albicans. Corpora albicans is all scar tissue, no yellow color at all. So this is preparing to be albicans, but it's still producing some progesterone. If fertilization occurs, this corpus luteum is going to persist quite a long time into the pregnancy until the uterus can produce all the progesterone for itself. The corpus luteum will persist. So another view of the uterine cavity. Oocyte that's ovulated should be fertilized in the fallopian tube. If fertilization occurs, this area here has a little sphincter that will close and keep the zygote out there until it's mature enough to embed itself, to eat its way, break down the endometrium and embed into the endometrial lining. If it's fertilized out here in the uterine cavity, it may not develop enough of these erosive cells, and it may just go on out through the cervix before it can implant. It may also, if it does develop these erosive cells too late, it may implant down close to the cervix. The cervix is not designed for implantation. If it embeds there, you're going to get hemorrhage and big time problems. Maybe have to have a hysterectomy. If it embeds too close to the cervix, it's going to be hard to keep that baby to full term. So mom may be in bed rest for 6 months of the pregnancy. As soon as the baby is weighing enough to push down and rupture the plug, then you usually have spotting bleeding, and you're concerned, you go to the doctor and they say, well, you're on bed rest from now on until the end of the pregnancy. They're not happy campers, and husbands have a miserable life until the delivery time. Okay, so internal os or orifice, external os. And endometrium, there's a functional layer that will slough off during the menstrual cycle, and then a basal layer that will reform everything. The endometrium is very glandular. It's going to store a lot of glycogen in the glands there. The zygote arrives with a sac lump as the yolk sac, but that's going to be depleted pretty fast. Then needs nutrients, and it hasn't set up the circulation with the mom yet, so it's going to use the glycogen that's available in the glands until it can set up the vascular exchange with the mom. So functional layer, you can see the glands. This is early, this is called the proliferative phase of the menstrual cycle. You're making new cells, you're extending the glands. This is going to get thicker and more glandular as the cycle persists. The lower part is going to be the stratum basale, or the basal layer that won't get sloughed off. And then below that is the myometrium, which is the smooth muscle. A lot of blood vessels coming out here. So the functional layer, this is during the secretory phase where glycogen is being stored. It becomes very tortuous, glandular-looking tissue. All of this will be lost if fertilization does not occur. So if fertilization does not occur, the blood vessels down in the myometrium, which are referred to not there. Okay, so in another. So down here in the myometrium, you have arteries that kind of spiral up, so they're called spiral arteries. They will, first of all, close down and limit blood to the functionalis, so the cells start to die, and then periodically they open up and release blood. Since the cells above them are dying, that blood is going to go out as part of the menstrual secretion. So you're going to have blood, you're going to have cell mass coming out as menstrual flow. So all of this is going to be lost. The basal layer will persist and then replace that in the next cycle. We don't have a prostate. So we've got greater vestibular glands, and these are analogous to the prostate, and then we've got paraurethral glands that are analogous to the bulbourethral glands of the male. So we've got the three, we've got the glandular system, but they're forming different things in the female. So external genitalia, this mound here that's full of fat, kind of hairy, called the mons pubis. It's right over the pubic bone. There's thick skin here that forms the labia majora, and that will have the hair on the outside. You separate and you look inside. So this is the big lip, and then there's a delicate, thinner lip called the labia minora. In the anterior part of this labia minora, you're going to see a little skin that will be covering the glands of the clitoris. The clitoris is analogous to the bulb of the penis, and then this covering is the prepuce of the clitoris that's analogous to the prepuce of the bulb of the penis. In here, this is the opening for the urethra, and then this is the opening for the vagina. The mammary glands have different stages of development. If you never get pregnant, they never fully develop into secretory cells. You could have them become secretory if you took the right hormones, and you could then nurse your friend's baby if you wanted to, or husbands, if they took the right hormones, their breasts would develop and they could nurse the baby. But how many guys are going to volunteer for that? Yeah, it's usually 0. You guys go, what? Do it. But you have the same tissues. You are prone to the same problems. You can get breast cancer too, guys, so you better check that out. You have what are called lactiferous sinuses. So the milk that is produced at the end of a pregnancy by all these secretory lobules will go out into small ducts that will empty into these lactiferous sinuses, and then they will empty through a common duct through the center of the nipple. The dark color around there is that's referred to as the areola, which just means round area. Got a lot of suspensory ligaments. The breast shape is mostly due to the adipose that is in that area. If you are flat-chested girls, you got the same secretory things as somebody who's got really big breasts. They have more fat in that region. The fat increases, the size of the breast increases during pregnancy, and then after you finish breastfeeding, it usually shrinks back down. Never to pre-flat-chested size, but it's most of the development disappears. Those suspensory ligaments, if you walk around without a bra to support them, the breasts get longer and longer and longer. And if you look at people in Africa and other places who don't wear brasiers, where do middle-aged women's breasts end up? Down by their thighs and close to their knees. So if you want that, then walk around without a bra. Okay, so on Tuesday we're going to pick up with 28 and we're going to talk about